Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Today, I am joined by Mr. Fahad Attar, who is a consultant trauma and orthopaedic surgeon, also a faculty member of the British Orthopaedic Association's Training Academy. Fahad, welcome to the Academy of Physical Medicine.
Thank you, Stephen. Glad to be here. Glad to be on
You've got
board.
a particular interest in the knee and in regenerative surgery, which intrigued me, and I think we're going to hear a bit about that today, aren't we?
Absolutely. My area of expertise is regenerative therapy for sports injuries and also osteoarthritis in joints. So we're going to talk a little bit about that, the conditions it's used in, the indications, and the patient journey through it.
Why is regenerative therapy only for sportsmen? Is it not applicable to other categories of patient?
I think at the moment, most of the data we have from research available for sports injuries, they've been using regenerative therapy, such as PRP or fat cell therapy injections for a few years now. More recently, it's starting to be used for the general public and population, especially for treatment of osteoarthritis, for tendinitis, and also for sports injuries as well. So at the moment, there's a big trend and move towards regenerative therapy medicine and surgical procedures to try and stay away from more invasive surgery, if you like.
Right. What does PRP stand for?
It's platelet-rich plasma. So
Okay.
PRP is basically a modality of treatment where we use your own blood. We spin it in a centrifuge, we get all the healing factors from the breakdown of the platelets, and then we inject it back into the area of concern. And it normally takes 15-20 minutes to do. It's done in a clinic setting, and we've seen some very good results for the right indications, the right conditions. Like I said earlier, mainly for tendinitis, tendinopathies, for early osteoarthritis, for early degenerate changes in the joints, and also for some sports injuries and muscle tears to try and get rehabilitation quicker, to try and get recovery quicker.
Yeah, the title we gave this discussion was looking at early osteoarthritis and avoiding joint replacement therapy. And of course, I wanted you to put in the regenerative therapy part of things as well. Should we go back to dealing with early OA to start with?
Absolutely. I think osteoarthritis, like we're all aware and see, is a very common condition. We see most people suffering with joints, especially knees, hips, shoulders, foot and ankle, with degenerative osteoarthritis. Now, osteoarthritis is traditionally more of a wear and tear disease where your joint progressively wears down as we grow older. Obviously, other impacts such as injuries, inflammation, and any other previous surgeries can accelerate the process. And in the current day and age we live in, we're seeing a lot of people who are more active, who have had lots of previous joint injuries, who are attending our clinics with early to moderate signs of osteoarthritis. Now, we have well-known treatment for severe osteoarthritis, which is a joint replacement treatment. But at the moment, there seems to be a bit of a bridge and a gap for that period of play, if you like, where patients have got moderate osteoarthritis, they're struggling with pain, they're struggling with stiffness, they cannot get back and do their own routine things they like to do, play a little bit of football, play with their kids outside. And unfortunately, there's no treatment modalities for them. So if they failed physical therapy or medication for analgesia, for example, they tend to be left and lost, if you like, till the arthritis gets worse, and then they come back and then they're ready for having a joint replacement. So the regenerative therapy really tries to bridge that gap, really, of those patients who are struggling with mild to moderate osteoarthritis, who failed conservative therapy. It's just to tell them that we do have modalities and options available now to actually help them with their pain, help them with their function, and try and delay the arthritis getting worse.
So you mentioned physical therapies there. Where does that fit in the sort of panoply of options that you have available for these younger osteoarthritic patients?
So traditionally, physical therapy always used to be an early stage of intervention and treatment modality. So once we see people in clinic, we normally start them off on pain medication. which is almost like a bridging platform with increasing from the most mildest pain medication analgesia and increasing it accordingly depending on their pain levels. And with that, we add in the physical therapy program for improving range of motion to keep the joint supple and mobile, and also to strengthen up the muscles around the joint, which take the pressure off the joint. But with regenerative therapies, what we're trying to do is to try and combine an approach where we're doing the physical therapy alongside the regenerative therapy, because we know physical therapy works and it works well. And if you've got people who are more comfortable with the regenerative therapy, the joints pain's a lot better, the mobility is more improved, they tend to do a lot more and gain a lot more out of physical therapy. So I think it's a combination approach really with the physical therapy and the regenerative therapy that we're looking at the moment.
Right. And are you excluding certain categories of patient from this, or are you looking purely at the active population, or if somebody younger who's, let's say, doesn't fit the criteria for healthy lifestyle comes in, would you be treating them as well?
Not necessarily. I think age is not really a criteria, because I think at the moment, if you've got mild to moderate osteoarthritis, and even though your activity levels and your age are variable, they're still suitable for the regenerative therapy procedures. So age is not really a cutoff. Secondly, activity levels, again, is not really cut off, because some people may be doing mild activity but still having pain and discomfort. Other people may be functioning at a quite high level and they're still struggling with pain. So the regenerative therapy is a standard approach that'll help them both. The only contraindications I would say is if you have patients who've got quite severe osteoarthritis, so they've reached a stage where most of the cartilage is lost, they're rubbing bone on bone, then the physical therapy with regenerative therapy have limited place really in the treatment and management, because regenerative therapy really doesn't have the options or the criteria then to start helping reduce inflammation, helping with cartilage protection, because the cartilage is already lost. So that's one category I would say is not really suitable, and we don't have much published data on them. But for early to moderate, most patients, it doesn't matter on age group or doesn't matter on activity levels, will be suitable.
Yeah, I'm tempted to ask, where were you 30 years ago when I needed you for my knee? But perhaps you were a bit young for regenerative surgery.
Yeah, I don't think I would into it at the moment, absolutely.
What's the actual process involved in what you're describing?
Right. So, like I said, there's two different modalities with regards to what we're trying to achieve. Now, the simple outpatient modality is the PRP, which is the platelet-rich plasma. Now, the way this works is it helps reduce inflammation, and it also creates the right healing environment for the joint to start functioning and working. Now, if people have been following the PRP trend in the market over the last few years clinically, you'll see that there's loads of different products available, and the PRP concentration is different and variable. The white cell concentration of the PRP is different and variable. So we really need to know what we're treating and how we're treating it before we decide what we need. So for PRP, what we normally use for osteoarthritic joints, we normally use either a concentrated one-off injection in an outpatient clinic setting. But for tendinitis or tendinopathies, we use a PRP with white cell rich content. And again, that's basically to try and create an inflammatory response for the body to heal. Now, that's the most common outpatient clinic option. Now, the other one, which is starting to gain a lot more momentum at the moment, is your fat cell therapy injections. Now, the advantage of the fat cellular therapy injections is that we're actually providing the cellular content for the healing. So most of us know fat and bone marrow have a lot of cells which can differentiate and can, regenerate cartilage. So the theory behind it is to try and get as much of a cellular approach into the joint to help with inflammation, and hence give a protection and some regeneration potential to the joint itself. And also alongside this will help with your pain, it'll help with your function and your movement. So at the moment, there's more data coming across from the fat cell injection therapy, but what data we're seeing is very encouraging. We're seeing some good results, and we're seeing good long-term cohort and follow-up of about 3 to 4 years at the moment. Now, we've got a video as well. If you want to just go through a patient journey, there's a good video on the fat stem cell injection, which we could play.
So let's have a look at that video. If you could tell us what's going on while Justin runs the video, that would be helpful.
So the patients in this suitable is the patient with the knee osteoarthritis. He's had early to mild osteoarthritis in his knees. He's had analgesic therapy, which he has failed. He's still struggling despite that. He's had a physical therapy program, which has partially helped him. And hence, he was a suitable candidate following done the right investigations with MRI and X-rays to proceed with a fat cell injection. The procedure is done under sedation. It's done as a day case procedure. Initially starts off with our plastic surgeon colleagues harvesting the fat. This is either taken from the abdomen or the thighs. Then we put it into a sterile syringe and we run it through a centrifuge, as you will see in a minute. Now, this basically spins to try and differentiate the different layers of fat. This is normally variable spin time, and once it comes out, it comes in different sort of sections. Now, what we're more interested is in the aqueous fraction. So we remove that, and then we left with a concentrated fat. Now, what we're trying to do here is we're trying to break down that fat into much smaller particles. So this is a mechanical breakdown process. And once this is spun through both the syringes on numerous occasions, it's normally 20 is what they recommend with the system we use. So we get a good, nice particulate breakdown of fat, which then we concentrate again in a syringe and we re-spin it in the centrifuge. Now, the second spin really tries to concentrate all the cellular structures that we need that will actually be used in the ultimate injection into the joint. So here we're putting it back into the sterile container and syringe, and we're going to spin it again through a centrifuge for a second spin. And once we come out, whilst that's ongoing, what we also do is we add in the PRP, as I indicated, mentioned earlier. Now, the PRP is taken from the blood. This is again spun in the centrifuge. So we have about 15 mils of blood, which will give us a yield of about 5 to 7 mils of PRP. And we have about 3 to 4 mils of your fat cellular concentrate that's coming out now. So we inject both the fat cellular concentrate with the PRP back into the knee joint, and that concludes your regenerative therapy. So here we're just trying to isolate the exact cellular content that we need from the syringes. That's all the fat that we're getting rid of. So you see there's not much yield here from the amount of fat we've taken. We get about 3 to 4 mils of good high concentrate cells. And these are then injected into the knee under a sterile technique. And following the injection of the cellular content, we also inject the PRP. So what the PRP does is it increases the healing factors and the environment in which the cells will work. So at the moment, most of the practices are including both of these with the fat cell and also the PRP at the same setting. Now, as Really said, this is a day case procedure, so it normally takes about 45 minutes and an hour to do. It's done under sedation, so you do not need a general anesthetic for it. Once it's done, within an hour or so, the patient is up and about. Once he's out of the effects of the sedation, he can start fully weight bearing and walking, and he's discharged the same day. We normally say it takes 2 to 3 days to take it easy. Don't do too much on the knee, rest it out, and then slowly he can get back to his usual level of activities and back to his sports in about 6 weeks.
I was going to ask about that because that's a remarkably rapid turnaround time, isn't it, for these new cells to improve what's going on in the knee. I was expecting you to say there would be 6 months of allowing the knee to regenerate before you actually started doing anything weight bearing or load bearing on it.
No, absolutely not, because in actually doing activity and weight bearing has a mechanical stimulus as well to actually help and regenerate the cartilage. So we're relying a little bit on that, as well as the cellular healing that's going on in the knee. So all we do is we avoid impact activities such as running, using gym leg weights or deep squats and things like that. But otherwise, routine non-impact activity, cycling, swimming, cross trainer, getting back to your walking, hiking, all that is absolutely essential.
So for your football player or your rugby player or your long distance runner, how long before they get back to their normal activities?
We normally say 3 to 4 months, and we say in 3 to 4 months, you slowly start back in a controlled environment and slowly build up what you do. So don't do too much too soon. And then within sort of 6 to 8 months, they should be pretty much back to doing high impact activities and back to sort of competitive sport. If we do have a lot of sports people come in to have these as well.
Yeah. Sheetal's asked a question, which I imagine is on everybody's mind. How much does it cost?
Sure. So the cost is variable and it depends on the PRP and the fat cell injection. So for the PRP, the cost at the moment is about 1,500 to 2,000, depending on which system you use. And that's an all-inclusive cost. And for the fat cell injection, it's about 5,000.
Okay. Why is it variable? You said because of those injections. Is it just variable depending on where you go or on the type of your body makeup? Or?
I think it depends on your condition, what you're treating it for. So for tendinitis and tendinopathies, PRP is sufficient because that gives us good results and we've got enough data that's been published to say that. But if you've got early osteoarthritis, I think what the general sort of people are trying to assess now is the cellular content is better than just the PRP because we're actually giving the cellular structure as well. So at the moment, there's a big trend towards using more cellular with PRP rather than just PRP by itself. And hence, I think if the patients are suitable for one or the other, they need obviously to be assessed properly. They need a full set of x-rays. They need an MRI scan where we can assess the cartilage damage to see if it's localized, what grade of injury it is. And then we almost tailor-make a plan for them that is going to be the most effective, if you like, in regenerating and giving them pain relief and improved function.
So I guess another important question is how widely available is the treatment?
So there's not that many clinics at the moment around the UK who are doing it, who are geared and set up for high volume. So we've got a couple of clinics down south in London. We've got our clinic up in Manchester, and we've got one of our franchises in the Midlands and London as well. So at the moment, although PRP is widely available and a lot of people are doing it, the fat cell injection therapy still is not. And I think more people start using it, more results start coming out, and more data we start seeing, I think it'll be starting to get more and more incorporated in daily routine practices.
And dare I ask how long before it becomes mainstream NHS therapy?
I mean, if I was to predict, I'd probably say 2 to 3 years. I mean, PRP, there was a lot of struggle over the last few years, but now a lot of NHS trusts are seeing the benefit of it, and they see the benefit of it compared to the usual cortisone injection that used to be given. So a lot more trusts are starting to incorporate PRP in their treatment protocols. But I think with the fat cell therapy, again, I think we're at least 2 or 3 years away before we start using it more routinely.
What do we need to be able to? What do we need to know to be able to advise our patients appropriately? Obviously, we're talking about osteopaths, chiropractors, physiotherapists here. Even though I treat very rarely now in clinic, even so, I see patients who come in and say, "I've just read this in the newspaper and I want this new therapy." Are we in a position to be able to do a bit of preliminary screening, or should we just say you've got osteoarthritis, make an appointment?
No, I think you can. I think it depends really on the stage of osteoarthritis. If you feel that you've been seeing someone for long enough and you've tried all the treatment modalities that's available to you, and they're not really progressing, but the recent scans or investigations they've had do not show that they've got severe osteoarthritis. Now, those are really the right candidates because there is some problem in the joint which is causing recurrent inflammation. They've got some cartilage loss, they're having some stiffness, and they're symptomatically struggling. Now, those are the patients we're really after because a lot of people with mild osteoarthritis, who are not symptomatic get on with it and, we don't need to do anything. Yeah. But the small percentage of people those are the right candidates. So for them, rather than say, well, we've tried everything, we cannot help you now, sorry, off you go till your arthritis gets worse on an MRI or X-ray, is probably not doing the right thing for the patient. So those are the kind of candidates to say, right, there are a few options available. You could look into it because you may be suitable for regenerative therapy. So if you then want to contact a specialist clinic, we'll then take you through the procedure, give you some advice and guidance, and you could take it from there.
Yeah, and Ron has said, if this avoids joint replacement, why is it not available on the NHS? Is it just because the NHS takes a while to catch up on the research and the evidence?
Absolutely. I think two elements to that really. One is obviously we rely quite a lot on NICE, rightfully so, and NICE uses both the cost effectiveness versus an outcome analysis. So at the moment, the cost is still quite expensive with regards to the overall gauge and advantage for long-term benefit. So at the moment, we haven't got data up to about 12 years, 15 years, 20 years that we have with joint replacement. So hence, I think it'll take a little while to sort of change that mindset for people to say that we're not really measuring like for like. And at the moment, we're trying to delay or even avoid joint replacement surgery. So I think that concept will come slowly, but I think the more data that gets published to say that, you know, people with similar sort of osteoarthritis have had 5 years, 6 years, 7 years worth of good results, improved function, and we've managed to stall the progression of the arthritis. And that's the sort of data we're really after. And I think we're still about 2-3 years away from that. And once that starts coming into the mainstream, I think, you know, you'll get people more in the NHS and in the private sectors getting a little bit more interested and starting to take it more seriously.
Well, I know you say you're a bit of a way away from that, and of course this will presumably depend on the age and severity of the candidate. But Melanie's asked, how long are you likely to defer joint replacement for?
Again, it's difficult to say because your starting point is important. So if you have someone who we can catch early in grade 1, grade 2, and treat them, then the hope is that we may not need to, you know, proceed with anything further. So worst case scenario is we've had a few patients who've had them done 5-6 years earlier, who've had some good results and have come back for a repeat. And when we've checked or investigated them again, they've not deteriorated much more than what we would normally have expected otherwise. So again, they're suitable candidates to have, you know, another injection at 5-6 years time if need be. So it's difficult to predict really because we haven't got that sort of long-term cohort and data to say at this stage when we intervened and we gave them regenerative therapy, we're looking at cross-matched, aged, and, you know, disease process comparable indicators if the other group went on to develop more osteoarthritis that needed a joint replacement. So at the moment, what we can confidently say is for early osteoarthritis, it helps with improvement in pain, in function, in movement, and get them back to their activity levels, which normally a joint replacement would not be able to do predictably.
Jess has asked about the research for this therapy on small joints, toes, fingers, and so on.
I think they've done it in small joints, especially for hallux rigidus in the feet. And again, they've had some early good results and data from that. Wrist joints and elbow joints have had quite a lot of studies going through as well. So at the moment, most usage has been in larger weight-bearing joints such as knees, hips, and shoulders, knees being the most predominant in most trials and published data. But I think lots of other data from smaller joints is coming through.
Do knees get so much attention simply because more people are attending for knee problems, or is there some other reason?
I think knee osteoarthritis is on the rise, and it's on the rise for 2 reasons, really. One is because people are injuring the knees a lot more, they're more active, they're doing a lot more. And secondly, the knee is a very complex joint. So if they've had meniscal tears, for example, and have had a partial meniscectomy earlier on in life, that speeds up the process of osteoarthritis. If they've had ligament injuries that have not been addressed and dealt with, it increases the range progress of osteoarthritis. So it's quite a complex joint. And what we're seeing now in literature is that previous injuries, previous knee problems, and people who are slightly overweight, putting a lot of brunt and weight onto the knees, all have, you know, a predisposition for them to develop osteoarthritis. And because the osteoarthritis in the knees is on the rise, we routinely are seeing a lot more patients with knee osteoarthritis in clinics, and hence I think a lot more data is coming out from the knees.
Nick's asked whether you think there's a use for this in spinal OA.
I think there is, especially for facet joint osteoarthritis. There are a few colleagues and friends of mine who are doing it, and again, with some good results. Again, it depends on the disease and the process and stage of the disease. But I think, again, spine is another area which is still upcoming.
It all sounds very positive. Amy's asked whether there are any adverse side effects from this or other complications that people need to be aware of.
Sure. So the side effects and complications are minimal, for the main reason really being we're taking your own cells from your own body and re-injecting them back in. So the side effects of, you know, having reactions or not agreeing with you or causing a lot of inflammation and swelling is all nullified. So the procedure is almost an outpatient procedure. So it's minimal small incisions for the fat harvesting, it's minimal small puncture wounds for the injections. So the risks are minimal. The only ones that patients need to be aware of is a very small risk of infection, a little bit of bruising around the fat harvest sites, which is reasonably common, but takes 1 or 2 weeks before it settles down. They can get a little bit of swelling or seromas around the area of the harvest, which is rare, but again, they need to be aware of that. And sometimes the injection in the joint itself, because we're injecting about 10 to 12 mils of fluid in, they can have a little bit of an inflammation in the knee. It can swell up a little bit. It takes a few days for it to settle down, so they need to put some ice and obviously avoid any activities or sports for the first few days. But apart from that, it's a very safe procedure, which is done under very good controlled environment, and it's done under sedation, so you don't even need any general anesthetic for it.
Yeah. Somebody called JH has asked about a 2-year-old meniscectomy with 70% loss of the medial meniscus, but minimal osteoarthritis. Is that too much cartilage loss for this to be a relevant therapy?
It is not too much cartilage loss, but it depends again on the activity levels of the patient, and it depends on how much symptoms they have. Because if they've lost 70% of their cartilage, they may be more suitable for having a cartilage replacement or meniscal replacement surgery to give them much more longer term benefit. And with that, if they have some degeneration and deterioration in the cartilage, we can back that up with the fat cell injection as well at the same time. So that'll be an ideal candidate to have the best of both worlds, really, to try and get the best outcome in the future.
Lorraine has asked, and it's kind of related to that, whether this treatment also works with surgical implants. Don't have any more specific details on what she's asking there, but
absolutely, I think I know what she's asking. And now I do quite a lot of cartilage reconstruction procedures, which are isolated cartilage defects. Now we use biosynthetic scaffolds to regenerate the cartilage, and with those I actually do use the fat cell concentrate or sometimes the bone marrow concentrate to load up the cartilage graft before we implant it in the knee. So we do use it with a lot of biosynthetic knee regeneration techniques for cartilage regenerative procedures, and they work again very well with that.
And somebody did ask earlier on, Louise asked if you have figures for the success rate of this therapy.
Yes, for 3 to 4 years, I think the most recent published data says 80% improvement in pain function on the modality scoring that they did. But at the moment, we've got quite a few trials and studies ongoing to try and see results up to about 6 to 7 years. And these are just with one-off fat cell injection for early osteoarthritis.
And presumably that compares very favorably with the alternatives that people might opt for.
Yeah, absolutely, because it either compares with your pain scores for people who've not had anything done, which is obviously means that they've dropped off their activity levels and they're still struggling with some joint pain and stiffness, and also with any surgical intervention or surgical procedures. So at the moment, we don't have a like-to-like comparison, for example, with a stage of arthritis and invasive surgery versus the fat cell. And I don't think that'll ever be possible because there's slightly two different grades of diseases we're treating. But I think with regards to just having a follow-up of cohort going more from a starting position with an early osteoarthritis going down to 5 years, 6 years, 7 years with regards to follow-up data, I think we've got good evidence to say that it does well from a pain perspective and also from a perspective of improving the function. Now, one other interesting element, what they're looking at the moment is repeating MRI scans at that stage to try and assess cartilage loss to see if it actually has a true regenerative potential in trying to regenerate the cartilage. And again, at the moment, we don't have enough quantifiable data to compare that with the initial scans they had. But again, that's work which is ongoing.
Any idea when we might see some results from that?
I think in the next year or two. I think there's a lot of studies that they'll be publishing most of their results in the next year or two. So I think this is an exciting sort of field and opportunity at the moment. And a lot of people are keeping their eyes open because it's a very good modality for the right indication in that cohort of patients that I mentioned earlier on, which are sometimes just lost really.
You've answered this question. I think Victoria's asked whether this treatment is useful for patients with a partial meniscectomy. Maybe it's worth saying, well, just how partial?
Exactly. I think it
be
depends.
appropriate?
Yeah, I think it depends on how much meniscus they've lost. And if they've lost a lot of meniscus and they're quite young and active, then I would say that they do need a meniscal replacement, which will be the best option. And then if they do have some degeneration in the cartilage, we obviously back it up with a fat cell injection, which will be very helpful. But if they've only had minor meniscus taken away, let's say 10, 15%, and they're starting to degenerate the cartilage, then yes, then they would be suitable for a fat cell injection.
What about a high-grade tibial plateau fracture? Sue's interested in whether you could use this to help there.
For the healing of the fracture itself?
Well, she says it's an old fracture, so I'm guessing she's talking about
Right, degenerate changes secondary to the old fracture. Yes, again, it depends on how quantifiable the arthritis or degenerate changes are. Sometimes when you've had previous fractures which are intra-articular, you do tend to lose quite a lot of cartilage, and you lose it quite quickly. So if it's still in its early stages, and if it's not yet gone down to grade 3, grade 4, then yes, there would be a suitable candidate to have it done. But obviously, we've got to assess in these kind of situations the overall alignment of the patient, because sometimes if they've had a fracture and they've fallen into either varus or valgus alignment, that may need correcting as well. So these are slightly more complex patients that we need to look at, step back and have more of a holistic approach. Even though the stem cells will work for that indication, if they've got other problems such as ligament problems or alignment problems, all of those need addressing at the same time.
Okay. Jess says, has it been used with Cartiva implants, which I'm not sure I'm familiar with? Often those implants have a limited lifespan, so could this be an option instead of fusion down the line?
No, not to my knowledge. I don't know of any cases or any studies alongside that. Joint fusion is a slightly different indication. It depends on what joint she's talking about specifically, but it's a slightly different indication. And that's, again, mainly for arthritis that's quite severe and in younger patients. So, rather than doing any joint replacement procedure for gaining more function in a younger patient, you'd normally do a fusion, and again, more common in smaller joints in the hand or something like that. So need a bit more specifics on that, but as far as I know, it's not really used in conjunction with that.
Yeah, I mean, I was surprised. We had Professor Bill Ribbons on the show some time ago, but I was surprised to hear that fusion of the hallux doesn't actually completely ruin people's gait.
Yeah.
And perhaps Sue's actually thinking about that. Or Jess, sorry, I should have said. Nick's asked a question about the serious weekend warrior and whether you would advise a trainer for the rehab process for someone like that. Now, again, that's quite an open-ended question there, isn't it?
Yes, I think I would actually, because I think we're seeing a lot of people who do a lot of active sports over the weekends, and most of our patient cohort include those patients. We actually see very few more competitive patients now, and we're seeing a lot more weekend warrior type of patients. And I think they are the right patients really, who are still reasonably young physiologically, not really from a chronological perspective, but physiologically, because they still like to be active. They want to get on and do sports. They've got their family they want to go and play with their kids. And I think if they've got problems with early to moderate osteoarthritis, I think they're suitable candidates. But again, if you're going to include physical therapy program with their treatment option, I think it needs to be more directed, and it needs to be more professional rather than just telling them go to the gym and get on with it, because I think they need a little bit more direction for that. So I think they do need a good specialist input, because they will really benefit from a good combination approach of regenerative therapy alongside a good physical therapy regime or program.
So given that that's the case, how much extra training do we physical therapists need to make sure that the rehab we suggest to people is appropriate?
You mean sessions-wise or time-wise? Because I normally
in terms of understanding what it is we're trying to achieve and how rapidly we should be trying to get our patients through their rehab.
Okay, so what I normally say is they need at least 2 to 3 months of good, well-directed program. Now, once they come in for any treatment, they lose a lot of muscle bulk straight away, because they're inactive slightly before because of their pain and problems, and they're slightly inactive afterwards because of the treatment options they've had. So I think within sort of 4 to 6 weeks, as you will be aware, they lose a lot of muscle bulk very quickly. So they need, I think, a good structured program, which should be at least 2 to 3 months to try and get them back to where they should be, and then a well-directed advice program with regards to what they should be doing, they shouldn't be doing, and that in tailor in conjunction with what they've had done and the problem they've got is ideal.
Poppy's asked an interesting question. She's asked whether this is appropriate in patients with an autoimmune condition.
I would say no, the short answer to that, because at the moment we don't have any trials or any results or data from that. I would also sort of include that to the rheumatological patients as well, because we've had a lot of queries and questions from rheumatoid arthritis. Now, their disease process is completely different, and we cannot really justify or have enough data to say that using the fat cell approach will help it, because more of an autoimmune problem, they have more destructive process, the joints deteriorate quite rapidly and quite fast. So at the moment, I would say no, but again, there may be some trials upcoming regarding that to see if you catch them early, can you protect the joint? But at the moment, we don't have enough data to go down that route.
I suppose it's also interesting to talk about where this might also be appropriate. And Jane has asked whether it could be used for an undisplaced labrum. Are there other areas where you see it being used in the future?
It can be, yeah. I think we use them for rotator cuff in the shoulders quite routinely, and labral tears in the hip, again, quite routinely. So it can be used, and it's got a wide variety of indications. So like I said, it's one of those things which is upcoming, and the more indications and the more patients we have with different pathologies we're trying to treat, we're trying to increase their success rate, trying to monitor their outcomes. I think that'll increase the indications we use them for. And again, it'll negate the need for surgery, for arthroscopic hip surgery for a labral tear, for example, arthroscopic shoulder surgery for partial rotator cuff tears, for example. All those could be negated if and we have enough data coming through that shows that the regenerative therapies work.
Yeah. Nicola's asked whether this is a once-only treatment.
It is. As for now, with regards to the fat cell injection therapy, it's just a once-only treatment. Very rarely you need to top it up, especially if they've done well and they have had it 5-6 years earlier. But most patients we're doing it for is just a one-off treatment. With the PRP, it's slightly different because the PRP, most published data and most of my personal data show that it will give you some benefit for about 18 months or so. Then people start developing the symptoms again, and they may need a repeat injection at that stage. So for the PRP group of patients, we've had patients who had 2 or 3 injections over the last 4 to 5 years as top-ups after 18 months or so. But for the fat cell, it's just a one-off injection.
And Joe's asked whether there might be any role for this in ankylosing spondylitis.
Again, I personally have not come across any data where they've used it for ankylosing spondylitis. So I'm not really aware of that, I'm afraid.
I mean, the costs that you mentioned earlier on seem reasonable compared to, say, joint replacement. But Amy's actually asked whether the private health insurers are covering this sort of therapy at the moment.
That's a very good question. Now, for private health insurers, since I've been sort of really pushing the regenerative therapy treatment modalities across, we've been speaking and having meetings with a lot of private insurers, and PRP seems to be something they've taken on board over the last year to 2 years, because that they weren't covering before. So I think it's just a matter of time before the fat cell and the bone marrow aspirate cell therapy starts, coming into play and then starting to accept it. We've had a few cases where we've pushed through with some clinical guidance and evidence and a lot of discussions and toing and froing from the insurers that they've accepted it. But again, it's not common, but we're trying our best to try and increase that and change the mindset.
Okay. Geraldine's asked about elbow OA. Can we see it being used there?
Yeah,
you did
absolutely.
mention it briefly earlier on.
Any osteoarthritis, as long as it's sort of early to moderate osteoarthritis, is a suitable indication.
Okay. And Nick says, would you work yourself directly with specialised therapists who are dealing with rehab?
Absolutely. I think that's very important, because I think the relationship between the surgeon and the therapist is vitally important, because you all need to be on the same page, including the patient. And I think that's when you get the best results. So I think most of the therapy is obviously well directed. So we get a lot of patients coming from far and wide who the therapists refer across to us. But once we get that, we actually have a meeting with the therapists themselves to try and find out what they've used, what they've done, to get a little bit of a program detail. And then once they've had the treatment and they go back, we liaise quite closely with them for progress reports, outcomes. And if they're struggling, it's always a two-way relationship, because I think that's the best way really to get the most out and benefit for the patient. So we work very closely with all our therapists.
That's interesting. I mean, I'm thinking back a very long time when I had the first surgery on my knee. I remember that the consultant then would tell the physio exactly what he wanted done on the knee. I'm not entirely sure that the physios even then listened. They still did the therapy as they thought was appropriate. But it sounds like a much more collaborative, or it is a much more collaborative approach these days to that sort of thing. Jackie says, would someone that's had a number of cortisone injections into joints or other significant steroid use over time, prednisolone, for example, for lung conditions, would they be suitable?
I think they would. Again, it depends on what we're giving the injection for and what the state of the joint is when we assess and give the injections for. Now, I'm not a big fan of cortisone or steroid injection into joints for the simple reason is that it actually has more of a detrimental effect on the cartilage in the long run. And obviously, it has the obviously effects that we know about, tendon ruptures and things like that when you give multiple injections. So I'm not really a big fan of them, but we do see quite a lot of people who've had 1 or 2 previous steroid injections who come back to see us. And if the joint condition is suitable for the regenerative therapy, we tell them it's better to progress the regenerative therapy than having a further cortisone injection.
Right. Sue actually asked for the name of your Manchester clinic, but I was going to go further than that and say, well, assuming that we've got patients who we think are suitable, how do we get the details of the clinics where this is offered?
Sure. So the clinic we run at the moment is run in the Northwest in Manchester, and we've got 3 different clinic setups for there. And we've also got a franchise, as I said earlier, on the Midlands and in London. So it's the Regenesis Clinic is the name of our clinic. And we've got a website, and we've got a contact number with the secretary details on there. And we've got a form as well that'll come directly through to query to one of the consultants. We work as part of a close-knit group with 3 to 4 orthopedic consultants, with a professor radiologist with us, who's a specialist in musculoskeletal care, and obviously a few therapists and anesthetists as well. So any query that comes through is contacted through our clinic, and then the secretary picks it up. She flags it up to one of us, and then we sort of arrange. I mean, at the moment, with the current COVID situation, we're doing quite a lot of e-consultations, which have been very helpful and easy, and it minimizes any exposure, any travel for the patients. And it helps as well for patients who are coming from far and wide, because they only need to come in for that one-off treatment option once everything else is done, through the e-consultations.
Yeah, and I'm presuming that the referral process is straightforward. You don't need to go through your GP. We could refer people straight to your contact details and make their own appointment.
Absolutely. We don't need any GP details, because we know that's a big hurdle for a lot of patients, trying to get GP appointments, trying to get that referral letter come through. And, they tend to wait a long time for that. So at the moment, I'm quite happy. We get contact directly from the therapist. We get contacted directly from the patients. So both those channels are open.
Would you expect them to have already had MRIs, X-rays of the joints concerned, or would you arrange that anyway when they come to see you?
Not necessarily. We arrange them ourselves, and we get, again, a wide cohort of patients who've had various different stages of investigations done. Sometimes they come in very early, sometimes they come in after everything is done. And my secretary is very good. She chases up all the results, brings them up onto our system within a few days. So once we've had a look at them, we've had an e-consultation, we have a clear idea and indication of, what the suitable candidates are, what the best tailor-made plan for them is, and then we contact them and we take it from there.
Nick's asked he's actually asked where you take bone marrow from, but I don't recall you actually saying that you do take bone marrow.
We used to take bone marrow. That's a good question, actually, because when I initially started off into my regenerative therapy approach, we started off taking bone marrow, because being an orthopedic surgeon, getting into bones is more easier than getting into fat. So when we go into bones, we normally go in the pelvic, in the iliac crest, and most of our bone marrow comes out of that. But more recently, in the forums I've been in discussing with more specialists in the regenerative sector, we found that the cellular content for the differentiation cells is a lot higher in fat compared to bone marrow, and it's not age dependent. And hence, over the last few years, my practice has tended to move towards the fat aspiration rather than bone marrow. But there's still a few cases we see at the moment where I do cartilage reconstruction, regeneration, where bone marrow is a little bit more appropriate. So we still take some bone marrow for those cases, but majority now are from a fat cell harvest.
When you showed the video earlier on, it seemed that a fair old quantity of fat was being drawn out. Are there patients where you would struggle to get sufficient fat, or is there always enough?
No, there's always enough. I mean, we do get quite a lot of lean sportsmen who come in, where when the plastic surgeon sees them, the jaw drops and go, oh my God, where am I going to get the fat from? But they always tend to get some from inner aspects of the thighs, outer aspects of the thighs, and a little bit from the side of the abdomen. So we've never reached a situation where we feel we've not managed to get fat. So there's always a place, despite how thin and how fit people are.
Yeah, for people like me, we could kill 2 birds with 1 stone, perhaps.
A lot of people do come in, actually. They say,
take a bit more fat, yeah. Fahad, there's one more question if I've got enough time. Poppy's asked, how about patients with osteoarthritis and an existing non-MSK autoimmune condition? Would immune suppression medication need to be paused to get the full benefit of reduced inflammation of the treatment?
I think it would be, if you're treating degenerative osteoarthritic conditions in a pre-existing inflammatory autoimmune condition, then yes, it depends on what therapy they're on, how long the therapy has been going on for, and we need to closely discuss and speak to the rheumatologist or which are the specialists they're under, because it's a slightly more tricky situation. But sometimes when we speak to rheumatologists and they say, well, you know, there are more under remission, we're not really actively treating it, we're happy to stop the medications for a while to see how things go, then those are the kind of patients where yes, you can try it for.
Yeah, brilliant. Fahad, thank you so much for giving up your time. What we'll do, obviously, is we'll publicise the contact details for the Regenesis Clinic so that people need to refer people on. They've got easy access to that. But of course, they can go straight to your website. And I really look forward to hearing sort of more of the results as they come in on where this might lead us. And perhaps one day you might want to take out your crystal ball and come back and say where you think orthopedic surgery is going over the next few years, because there have got to be other things in the pipeline which might help us all.
Yeah, no, absolutely. It's been a pleasure having coming on your program, and
entirely our pleasure. Thank you.